So how do we assess this pain? So most of the patients in the ICU are ventilated, and at times they are not able to communicate. So on ventilated patient, if they are able to communicate, there is one scale, and if they are not able to communicate, there is two scale. You can choose whichever you want to use. So this is the gold standard. The patient is on mechanical ventilator. It is called a numerical rating scale with visual support. Now, patient is able to communicate via signs, but patient is not able to communicate via verbalizing. So patient is a ventilator, can communicate 1 to 10, and he will say that now the patient is 3, and now my score is 2. So this way you can understand that this much pain the patient is having. That's why there is a pain score chart in your ICUs. How much is the pain, and they need to reevaluate and then act on it. Same dose of analgesia for one patient, it will suffice, but for another patient, it will not suffice. Now, but if unfortunately many patients in the ICU are unable to report, so what you will do? So for them, there are two scale: critical care observation tool. This is their pain observation tool, and there is behavioral pain scale. These two are the most varied one. We use BPS in our ICU. So this is just to give you an idea how this is done. Critical care pain observation tool, CPOT. Now you see the facial expression, body movements, muscle tension, vocalization, compliance with ventilator intubation patient. You are just observing these things. Facial expression, how? No muscular tension is observed. Face is, there is no expression on the face. Or about all of the facial movements plus eyelid are tightly closed. The patient is grimacing in the pain. The patient is keeping eye closed. That means patient should be given score 2. So these are the things. If the patient is frowning, brow lowering, orbit tightening, that this patient is having pain. So body movements, muscle tension, compliance with the ventilator, alarms not activated. If the patient is having good ventilation, then 0. If the patient is blocking ventilation, alarms frequently, that means fighting with the ventilator too. So this type of things you need to measure, and between 0 to 8 you need to observe. This is a behavioral pain score. This is a little bit easier. That's why it is being used more frequently. Facial expression, upper limbs, compliance with the ventilator. Only 3 things. If the facial is relaxed, 1. Grimacing, 4. Fully tightened eyelid closing, brow lowering, 2, 3. Upper limbs, no movement. The patient sitting silently on the no pain, but if the patient is retracted because of the pain, 3. Like this, compliance with ventilation. Unable to control ventilation, tachypneic. Patient is very tachypneic, not able to control, 4. Patient is tolerating ventilator, coughing but tolerating ventilator most of the time, fighting with the ventilator, 3. So this way you observe 3 things and you write down the score. So any score about 2 in CPOT or in BPS more than 5 indicates the presence of pain. Now the importance of this, you need to understand that it is important that all this, whether CPOT or BPS, they can identify the presence of pain, but they cannot determine the severity of pain. While our visual scale, in visual scale, the patient was having pain and the patient was saying that I am having this much amount of pain, I am having this much amount of pain. On the scale, you can grade. But in this CPOT and BPS, in which you are evaluating that this patient is having pain, so it can tell that something needs to be done to this patient because he or she is in pain, but it will not tell how he or she is perceiving how much is the severity of the pain. So this you should keep in mind. Many times the residents tell me, sir, pain can be measured from hemodynamic instability like tachycardia. The patient is tachycardic, that patient is having pain. So the studies show they're not found to be reliable indicator, though they can act as a trigger to observe the pain, or they can use them as a trigger to monitor the pain like CPOT or BRS. The visual support is still the gold standard. Now, we have done all these zigzag sort of things. We have identified the pain. We're doing scaling. Everything is doing. Whether this assessment of the pain or whether this whole exercise is having a positive impact on the patient or not, this also you need to understand. So, does the systemic assessment of the pain benefit patients? So, they have seen that increased pain assessment, improve pain management with pain scores, greater titration of analgesics. You can titrate analgesics and frequently related sedative use. Because the patient is in pain, he is fighting on the ventilator just because of pain, or you give just a sedative. So if you identify the pain, you correct the pain, then there are chances that you need not to give any sedative dose. reduce complications of VAP, good patient satisfaction. But important is there is no clear impact on the duration of mechanical ventilation, ICU length of stay or mortality. However, some studies have shown many benefits. So the patient comfort, the need for sedatives, reduce ventilator-associated pneumonia are there. But on ICU length of stay, on the duration of mechanical ventilation, the results are not clear. But these benefits which are there, they are also not small enough. They are good enough to use these all things. So this is the smallest part. Once you have identified pain, once you have assessed the pain, once you have decided that you need to monitor and you need to give some pain therapy to this patient, this is the last part, which is the easiest, I would say. People think it is the most common thing, it's the most difficult thing, pain management. But I think I'll tell you, the management part is not so difficult. Identification is more difficult and more important. So I'll cover in the slides, but I'll give you 3 basic principles. Recently, Anglo-sedation is the term which is being used and which is coming in the international guidelines. Means analgesia, you give analgesia to handle the pain more frequently, so the need for sedation decreases. So every time it should be followed by like opioids, handle the pain, and if needed, then you give benzodiazepines or any other thing for sedatives. Secondly, opiates are still the first line therapy of managing pain in the ICU. Secondly, you have paracetamol, NSAIDs don't have a much role. And the other agents are adjuvants, which are used on case-to-case basis. So sedation, Anglo-sedation, there is a growing evidence that lightly sedated patient is beneficial over deep sedated patients and now recommended. So what they do is their paper highlight that prioritizing analgesia before anxiolysis, hypnosis, sedation. You start with opioids, fentanyl infusion, or some sort of opioids, morphine, so that the pain is relieved, and then if needed, then only you give the benzodiazepines. So this is what we see in the clinical practice. So how do we manage? So again, reduce duration of mechanical ventilation, and okay, this is analgesic-based sedation reduces the amount of hypnotic required. This is improved, so outcome is improved. This is the same thing, which is repetition. So what is the role of opioid analgesics? So opioid analgesics are many. They act on different receptors, mu, kappa, and delta, but they all act through the mu receptors. And in this has morphine, fentanyl, sufentanil, remifentanil, afentanil are there. Every agent, basically, which one to use, it depends on unit to unit. No one has got a priority over the other. The staff, how much is familiar, how much the team is familiar with titrating of those, how much you have used, what side effects you are seeing that face. We use fentanyl the most. Morphine is not available frequently, but if available, it is wonderful drug. Remifentanil, afentanil are short-acting drug. The problem is the good thing is short-acting drug is you can titrate them very frequently. But the problem is that as soon as you stop, within 1 hour, you need to reassess the patient, because if the effect has gone away and you need to give more pain, you need to start or de-escalate the pain during that particular period. While fentanyl or morphine have a little lasting effect. Okay. There are many routes available: IV, oral, sublingual, transdermal patches. But IV is the choice in the ICU because we can titrate them. So intravenous route fulfills the most of the requirements. Again, what is they are saying, the decision will be influenced by the opioid being used, unit familiarity, and the complex interplay of factors in a given patient. Paracetamol is one drug which is useful, but it does not reduce that much amount of pain in patient. It should not be used as a first line. They have seen that in patient experience significant pain, high opioid requirement, or who are experiencing side effects from opioids, like constipation or respiratory depression, all things, then paracetamol may be of some benefit and should be covered. Paracetamol should not be primarily used though it is for mild pain you can use, but in refractory pains, the guidelines say that once you have given opioids, if it is not responding, then you can add paracetamol. NSAIDs, insufficient role. AKI, GI bleed, all these are very common. As far as possible, avoid NSAIDs in the ICU, except for 2-3 conditions. And one is some post-op cardiac surgery patient. In them you can use. Young patients which don't have any comorbid conditions, you can use, and non-comorbid patients. So if the patient does not have no comorbid conditions, if the patient is very young, and in some cardiac surgery patient, NSAID have a certain role. Then there are different ketamine, dexmedetomidine has come up. The units which are familiar are using for light sedation and all those things. So, and neuropathic pain, we don't use that much gabapentin or other thing. But the choice is your opioids followed by paracetamol, and in some situations you can use